Welcome, Superior Capsule Reconstructions, lesson learned for indications and surgical technique. The original steps were repair the subscapularis and the infrasmatus, measure the defect at 45 degrees abduction, use a 6 millimeter fasciolata graft, fix the graft to glenoid with 2 corkscrew anchors, fix the graft to humerus with compressive double row, add an anterior posterior side to side margin convergent sutures, and the results are really impressive. Where are we now 9 years later? If you look at the anatomy, the coracoid ligament and the superior capsule are tightly bound together, and you look at the figure on the right, the arrowheads. The thickness of the superior capsule is 1 millimeter, the coracoid ligament is 4.5 millimeters, the superior capsule plus the rotator cuff laterally is 5.5 millimeters. The footprint of the superior capsule on the humeral side goes from the biceps to the posterior infrasmatus. On the glenoid side, it goes from the coracoid to the scapular spine. The superior capsule joins the rotator cuff as one unit at the rotator cable, and this junction is 20 millimeters from the medial footprint of the rotator cuff. The massive rotator cuff tears are missing the main conduit for abduction force transmission, and that's the defect or the main pathology. If you look at mechanical studies, the superior capsule reconstruction with a 5 millimeter fasciolata graft versus a supraspinatus tendon graft corrects superior translation. There's no difference in tensioning at 15 and 45 degrees of shoulder abduction. A superior capsular reconstruction with no side-to-side sutures increases superior translation. If you do a posterior side-to-side suture, you restore superior translation. A humeral dermal allograft at 3 millimeters only corrects 50% superior translation because the graft elongates 15%. A humeral dermal 6 milligraft seems to correct superior translation. If you look at biology and you look at animal studies, a rabbit fasciolata graft and a humeral dermal allograft both heal to bone, but the fasciolata graft has better collagen density orientation. The humeral dermal graft has inflammation. This could be delayed maturation or rejection. In humeral retrieval studies, there's slow incorporation, but there's areas of no new collagen formation and persistent elastin. So 7 months, it doesn't completely incorporate, if it ever does. If you look at mechanical studies of the explanted graft versus unimplanted graft, you see a dramatic decrease in loaded failure, and you lose the toe region. So graft is different. It's not the same graft you put in. Look at outcome studies. The fasciolata graft seems to do better in change of ASE scores than a humeral dermal allograft, but they both are greater than MCID. You get double the failure rate with a humeral dermal graft. If you look at individual studies, the fasciolata graft, 90% heal, and the ASE score changes 63 points. They seem to all go to work and return to sports. Pseudoparalysis is also improved with the fasciolata graft in 93 and 60 and 96% of the time. The external leg time is all negative in healed grafts. It doesn't matter if you have fat infiltration in the rotator cuff muscles, they seem to do okay in reverse pseudoparalysis. Deltoid weakness does matter. This is also confirmed by another study. You get improved pseudoparalysis in 94 and 84% of the cases. It may take 8 months. You never get improvement in pseudoparalysis with an irreparable subscap tear. So you need to repair the subscap or have repairable subscap. If you look at humeral dermal grafts at 18 months, you get a 55% rupture rate in the first go around. You get good improvement in the ASE score. You get better improvement if the grafts heal. If you get atrophy of the subscap, they seem to have a lower healing rate. You get success with thicker grafts, 3 millimeter grafts, but 7 cases went on to reverse short arthroplasty out of 54. The second revision of this, one single author, had a impressive healing at 85%, and the ASES score was a little bit higher, and there was no difference between Hamada 1 and 2 and 3 and 4. Now, the proposed difference is from 2 factors, the delay in overhead motion and strengthening at 4 months, not 3 or 4 months, and the technique, 3 glenoid anchors and 2 medial anchors with double horizontal sutures, double horizontal mattresses, and you repair the infrasmatus over the graft. You do get reversal of pseudoparalysis in about 90% of the cases. If you have poor quality tendon but it's repairable, you can add this as an augmentation. They seem to do pretty well. The ASE score goes from 43 to 94, and about 80% of the grafts are intact or partially intact. Now, is this generalizable? It may not be. In a group of 6 fellowship-trained surgeons, there's a 65% clinical failure rate. And the risk factors were women, 13 out of 13 all failed. Fat infiltration and surgery learning curve less than 10 was risk factor. So what we learned, indications, it needs to be, is it good for a irreparable rotator cuff tear, repairable poor quality tendon. You need a repairable subscap. Subscap is the key. Hamada 1 and 3, okay. You need a joint space. It's good for pseudoparalysis of forward elevation. But if you have good forward elevation and you have pseudoparalysis of external rotation, I'd recommend an arthroscopic latissimus transfer as shown on the right. Beware risk factors when using a humeral-dermal allograft, female sex, and a learning curve less than 10. Contraindications, active infection, and deltoid weakness because of axillary nerve palsy or cervical disc. Donor site morbidity, humeral dermal graft versus fasciolata. Now, obviously, you don't have donor site morbidity with the humeral dermal graft. That's the advantage. But if you take a fasciolata, you can take it from proximal femur or mid-thigh. They both have the same mechanical properties. The complication reported from a proximal femur graft is gluteal discomfort, but the patient was able to play badminton. Okay. It's more well studied with the mid-thigh. You get 13% minor complications, hematoma, herniation. If you ask these people specifically, would you undergo the same surgery? 95% would say yes. Does the harvest thigh bother you? 45% yes. I don't have the answer, which is better. You have to ask your patient and talk to your patient. This is a third time redo rotator cuff. She presented to me after 3 surgeries. We went ahead with a thigh fasciolata graft. She was happy with the result as shown on the bottom left, but she had loss of knee flexion, and this bothered her with yoga, but she definitely would have the surgery again. So what I learned is you want to reestablish the coracoid ligament, you want to fix the rotator cuff to the graft, and you want to reestablish capsule continuity. And how I do this, on the glenoid side, I use 3 double-loaded anchors. And I repair the anterior and posterior anchor with a vertical mattress. I repair then I do 2 double mattress sutures. On the humeral side, I use 2 to 3 triple-loaded anchors, and I do double-loaded mattress sutures. I do bridging, and then I have 2 sutures to go through the rotator cuff remnants and laterally and repair them back down to the graft. I also put a horizontal suture in to repair the medial remnant to the graft. And it's based on the anatomic studies. It's 20 millimeters from the medial footprint anchors or 10 millimeters from the lateral edge. And I also use in a circle these loop sutures to pass the sutures when I have the graft in the joint through the graft. So these loop sutures are helpful to pass the sutures through the graft. My final construct is going to be 2 horizontal sutures suturing the infrasmatus to the graft and a vertical mattress suture suturing the supraspinatus to the graft. Here's a video. Now, it's important to check the subscapularis. If you have a tear of the subscapularis, you need to fix it. And I fix it in this case with a horizontal and 2 vertical mattresses behind the horizontal. I tied the horizontal first, and I tied the 2 vertical mattress sutures, and I got a good repair. What I'm going to also do is, this is a poor quality redo cuff. And so I'm going to do a posterior release or slide, and I'm exposed to glenoid, and I'm going to clean up the glenoid to get good bleeding bone. My first anchor is an anterior anchor, and it's right where the coracoid hits the glenoid, and I put that anchor in. I'm going to put a middle anchor through Neviser's portal and replace that with a cannula, and I'm going to use to push the graft in through a suture loop. That's my posterior anchor. So I got 3 anchors. All anchors have 4 sutures through. I'm going to clean up the glenoid. Here's the bicipital groove. The first humeral anchor is going to go 5 millimeters anterior or posterior to the bicipital groove. And this is a triple-loaded anchor. And I put my posterior triple-loaded anchor. I'm going to measure the graft at 20 degrees of abduction. And I'm going to add on the anterior posterior 10 millimeters medial lateral 15 millimeters, and it's 5 for the glenoid and 5 for the humerus. The graft is tough, so I use the glenoid anchor inserter to push holes through the graft. And you got my graft horizontal mattress for the anchors and my loose sutures. So I'm going to pass 3 sutures from the anterior anchor and posterior anchor, and I got that loop suture I'm going through an advisor's cannula to help pull the graft in. And I'm going to use that loop suture to pass the 4 sutures from that middle glenoid anchor through the graft. So I'm passing my sutures graft in. I'm pulling it through an advisor's portal. And then first thing I'm going to do is I'm going to tie the graft posteriorly with that vertical mattress suture, just to secure the graft. Then I'm going to go anteriorly and pull that vertical mattress sutures out and tie the graft anteriorly with the vertical mattress sutures. So the anterior anchor on the glenoid has a vertical mattress suture. The posterior glenoid anchor has a vertical mattress suture. And then I'm going to pull the sutures through the graft, my middle anchor sutures through the graft. Then I'm going to tie a double mattress suture. And I did the first stitch outside the cannula, and then the second stitch is what you're seeing. It's a double mattress suture. And then I'm going to go, that's posterior. Then I'm going to go anteriorly and tie the second double mattress suture. I'm going to pull the sutures out of the cannula, tie them over a Wissinger rod, and then crush the sutures down, tie the second knot. So it's a double horizontal mattress suture. Then I'm going to pull my cuff suture out, my previous plate horizontal cuff suture, and I put those humeral anchors through, and I pass the sutures through, and I'm going to tie my horizontal double mattress suture here, so I secure the graft to the humerus. And I do this again at about 20 degrees of abduction. Now I'm going to take my sutures I put through the graft, and I'm going to use those to pass through the infraspinatus medial remnant at the musculotendinous junction. And this is going to be a horizontal mattress. You can see the horizontal mattress goes through the medial remnant at the musculotendinous junction. I'm going to dock that. Then I'm going to get my sutures from my posterior medial anchor, and I'm going to do a horizontal mattress to the lateral infraspinatus remnant. So I got sutures through the medial remnant through the graft, and I'm going to put sutures through the lateral remnant, as you see, 2 horizontal pair of horizontal sutures. And I'm going to tie down the graft, tie down the infraspinatus to the graft here. And I'm going to tie here the infraspinatus laterally down to the graft and down to the humerus. And then I'm going to look at the subscap to see it, or supraspinatus, I'm sorry, to see if there's any remnant. I'm going to put a banana through there. I'm going to pass just a simple vertical mattress suture there because the tendon is kind of not great quality. But I'm gonna tie the supraspinatus laterally down to the construct. And then I'm going to do bridging technique, suture bridging technique. I'm going to pull a suture from the medial and lateral anchor and then place them through a knotless anchor and to compress the 10 millimeters footprint down to good bleeding bone. So I place those medial anchors about 10 millimeters away, so I get 10 millimeter compression of footprint. Now I'm going to do a margin convergence suture here, repairing the infraspinatus and the supraspinatus solidly down over the graft. So the graft is now, the rotator cuff is now sutured to the graft and sutured to the humerus, and the graft is sutured to the humerus and glenoid in solid construct, as you can see here. It looks great. So I think of the graft as a passive restraint to superior elevation, and a conduit for rotator cuff force transmission. The graft biology is the key. If you use a humeral allograft, you want to delay active overhead motion for 4 months in sports for a year. And remember that you may have a good result with a reverse short arthroplasty after superior capsule reconstruction. It may not be a great plan B bailout. And thank you.